Hello everyone. Before I begin this online presentation, I would like to thank Dr. Davila, Dr. De La Fuente and Dr. Varios for the opportunity to share some slides with you. I am sorry I will not be able to make it in May. For the next 10 minutes, I will present a sonoanatomic correlation that I hope will help you approach the anterior elbow during ultrasound-guided procedures and sonosurgery. As you all know, the elbow is made up of three joints, joined by a single capsule. I would like to point out that the most proximal part of this capsule has an interarticular but extrasynovial fat pad that overlies the coronary fossa, and it can be displaced in situations of elbow joint effusion due to a number of causes. More distally, a thinner capsule can be observed as the anterior recess, and overlying that capsule is the brachialis anterior. In this longitudinal image, the differences about the proximal and distal aspect of the capsule can be observed as well. Classically, the anterior aspect of the elbow has been approached by the concept of the cubital or antecubital fossa, which is a triangular space limited superiorly by the intercondylar line, an imaginary line we could say, medially by the pronator teres, and laterally by the brachioradialis. Its most superficial or aspect or roof is made out of the deep fascia and lacertus fibrosus, while the deep surface is made out of the brachialis anterior muscle proximally and the supinator muscle distally. For didactic purposes, we will divide this fossa in three parts: the central part containing the distal biceps brachitendon complex, a lateral fossa, and a medial fossa. Let's begin with the distal biceps brachitendon. The first thing to do is to understand that it is not only a single structure, but it's rather a tendinous complex made out of four main components that may have different implications in pathological situations or that might be approached differently during certain procedures. The tendinous complex arises from a wide intramuscular aponeurosis, which is flat but becomes oval-shaped laterally, becoming the distal biceps brachitendon, and remains flat as a flat structure, becoming the external aponeurosis or lacertus fibrosus medially. There's a fourth component, which is a sheath, not synovial, but a sheath indeed, that carries out the innervation and blood supply to these extramuscular structures. Also, it is important because it might become hypertrophic in some injuries, in some contexts. As you can see in the ultrasound clip, we can see intramuscular aponeurosis that becomes oval-shaped and becomes a tendon and remains flattened medially, becoming the external aponeurosis or lacertus fibrosus. Now let's dig in. The internal aponeurosis is as long as a third of the muscle belly length. It might have different conformations in the sagittal plane. The most common type is a single aponeurosis horizontal within the muscle belly, but as we can see, several other configurations might appear. Focusing on the tendon, it is important to notice its course from superficial to deep and its 90-degree twisting, as this will require progressive transducer tilting in order to avoid or use in our favor the anisotropy effect of the tendon. As it gets deeper into the cubital fossa, it might be more difficult to scan. Also, this tendon is composed of two main components, the long head and the short head component. These two components are functionally divided by an endotendon septum, mimicking a quaternary tendinous structure. Now, although it might seem a small septum, it can readily be observed macroscopically, and it also gives a functional independence in between two components, as they can twist or bend upon each other. We will see later during an ultrasound scan. Also, during using the anisotropy effect tilting the probe, we can see this hyperechoic septum and the anisotropy effect of the lateral and of the long and short head as they become anisotropic. As we said, this tendon twists 90 degrees from superficial to deep, and so the short head becomes more superficial and attaches more distally, while the long head becomes deeper and attaches more proximally. Now, as we can see in this clip, from distal to proximal, we see the long head going from a deeper position to a more lateral position, and thus twisting or bending independently from the short head. Now, usually the tendon will be approached anteriorly. However, as you can see in this clip, during pronasupination movements, the radial tuberosity appears on a posterior window and thus can be depicted by a posterior approach, which can visualize and able to visualize the whole footprint. So keep that in mind. There are also two bursae in the cubital fossa, namely the bicipitoradial and the interosseous bursa, which occasionally communicate with each other. The bicipitoradial bursa is located between the radial tuberosity and the biceps tendon and serves to reduce friction between these two structures. Now, I would just like to mention two things about the lacertus fibrosus. The first one is that its width may vary greatly and thus have different consequences in injuries to this complex. And this seems to be, or studies point out that this seems to be rather an atomic variant, just genetically based. Also, the lacertus fibrosus might have its independent muscle belly. It's important, again, to scan it from the internal aponeurosis to the external to ensure that you don't miss out the smaller ones. The second fact is that we have seen that during overuse of this structure, it might become adaptively somehow much thicker, as we can see in this population of office workers, which had a smaller thickness when compared to semi-professional tennis players. Here we can see this aponeurosis is even thicker than the tendon, while the ones of office workers is thinner than the main tendon. So this complex may adapt during overuse. Alright, let's move on to the medial fossa. The two main structures are the median nerve and the brachial vessels. Proximal to the joint line is the point where they become the most superficial, just before passing deep to the lacertus fibrosus and the pronator teres. They are found between the biceps brachii and brachialis anterior muscles. The nerve always medial to the artery. However, watch out for a high arterial division. In these images, we can see how the nerve then becomes deep to the external bicipital aponeurosis or lacertus fibrosus and also deep to the pronator teres muscle. If we look at the ultrasound clip, we can see the nerve becoming deep to the pronator teres. And with this dynamic maneuver, it seems as if a wave was tubing over a surfer. Also, if we stop the clip at the end part, we can see a thickening of the deep fascia. At this point is where the lacertus fibrosus is attaching to the fascia, to the deep fascia over the pronator teres. Finally, distally, as the ulnar head of the pronator teres arises, usually a small muscle belly can be seen passing under the nerve. Now, if we take a look at the ultrasound clip, the nerve, the brachialis attachment, and suddenly a small muscle belly, which is the ulnar head of the pronator teres. Again, here, small belly. As we saw in the clip, the muscle belly was hypoechoic and thus had a muscle nature. However, some variants have been observed, as it can be a mixed tendinous and muscular belly, or even sometimes just be this ulnar head, just be a tendinous structure. So watch out for these variants. Another thing to notice is that when the nerve comes out of in between muscle bellies, the anterior interosseous nerve appears. So if you scan carefully, you can also see this. Now a quick mention, because although these structures are not in the medial fossa, they might interfere with the median nerve path. One is the Ganser muscle, as you can see in the image, and the other is a supracondylar process, all together with the ligament of Struders. And this would be the sonographic images. So finally, let's move on to the lateral fossa. The main nerve found in the lateral fossa is the radial nerve, while the accompanying artery is the recurrent radial artery, and the satellite muscle, the brachyradialis. On this cross-section, we can see how more proximally the main muscle in contact with this neurovascular bundle is the brachialis anterior, while the brachyradialis starts to arise proximal to the or at the level of the supracondylar ridge. Let's look at this clip. Now, many times the brachyradialis doesn't have a clear limit with the brachialis anterior muscle. However, during a dynamic scanning, we can see these limits. These limits are also diffuse anatomically, and sometimes during dissections you can see how they even have somehow a common origin, the brachyradialis with the brachialis anterior. Now if we move on to the more distal part of the lateral fossa, we can see the radial nerve dividing off and giving mainly its superficial branch and its deep branch, as well as the motor branches to the lateral compartment muscles. As the deep branch reaches the Frosch's arcade, there's an important thing that we must mention, and it is that at this point, as it enters the supinator muscle, the radial recurrent artery gives off a high number of small branches that are known as the leash of Henry. In this leash of Henry, what implies is that when we turn on the Doppler, we can see a lot of Doppler signal around the nerve, and this is physiological. This must not be confused with an inflammatory process. Just a final image about the nerve, the deep branch, somehow entering the supinator muscle and becoming the posterior interosseous nerve. Now, there is some discrepancy in terms of nomenclature, as some authors prefer to already name this nerve as the posterior interosseous nerve when it divides off the radial nerve proximal to the supinator muscle. But this is still a matter of discussion. Now at this point you can see the nerve, and when we turn on the clip we can see how the deep branch or the posterior interosseous nerve becomes intramuscular through the arcade of Frosch, while the superficial branch remains superficial to the supinator and deep to the brachyradialis. Another important fact, as you can see, is a widening of the posterior interosseous nerve as it enters the arcade of Frosch. Now again, this must not be mistaken for the pseudoneuroma, a compression pseudoneuroma, as it is a physiological image. You can actually kind of see it in the anatomic cadaver dissection. Thin, 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 it becomes a little wider and thicker just before entering the Frosch's arcade. Now, another quick bonus, as this structure is actually in the anterior elbow and it crosses the anterior elbow, but it does so outside the so-called cubital fossa. This is the musculocutaneous nerve which travels in between the biceps brachii muscle and brachialis anterior muscle and can be very easily depicted with a dynamic scanning of this region. And then as it reaches the elbow, it actually becomes superficial to the deep fascia, but it does so at a point crossing almost always perpendicularly deep to the median cephalic vein, which is one of the median elbow veins. Also, this vein might be subject to anatomic variance, so it's not always constant that this happens. However, if you scan from proximally within the muscle bellies to distally and look for this crossing deep to one of the elbow veins, let's say, um, you might really well depict it. So, just some final messages. Anatomical knowledge is essential. This might seem obvious, but we tend to forget it. And thus, if we don't deep in the complexity of certain structures, we might not understand or might not know how to find some ultrasound images. Now, physiology is as important as when we sum up our anatomical knowledge to the function of a certain muscle or tendon, we might better understand our dynamic maneuvers and even design new maneuvers that can help us better depict the images we're looking for. Finally, when we do not understand an ultrasound image or find a specific, where we do not find a specific anatomic structure, we most likely need to get back to basics, go back to the section room and contact our primary care anatomist. So thank you very much. I hope this was useful to you all, and I hope that you have a great time in May.